Welcome to AETCM, the emergency medicine channel. 27-year-old Primie Gravida came to the ER with complaints of pain in the left lower limb calf. On 10-second initial assessment, airway was patent, no pooling of secretions, breathing, respiratory rate was 16 per minute, saturation 96 in room air, circulation BP was 120 by 80, pulse rate 90 per minute, GCS was E4 V5 M6, and temperature, she was afebrile, and GRBS was 110 milligram per deciliter. Coming to the history, 27-year-old Primie Gravida at 8 weeks and 1 day of gestation, spontaneous conception, came to the ER with complaints of cramping pain in the left lower limb calf muscle since 3-4 days. There was pain on walking and on touch. There was no history of fever. On examination, there was no redness over the region. There was mild swelling. There was no increased temperature over the region. Mild edema in the left leg only. So after that, sir, we went ahead with an ultrasound Doppler study of bilateral lower limbs. That report showed a deep venous thrombosis of left popliteal vein, soleal vein, and proximal tibial vein.
Okay.
After that, we started her on injection enoxaparin, 60 milligram subcutaneous was given stat.
Okay. So this young female, when you present this case, no, so your history was acute onset of left lower limb calf pain and edema,
yes,
right?
edema.
Pain and edema, which are one of the 3 most common findings are pain, edema, and redness. No, not redness, warmth. Pain, edema, and warmth are the 3 most common presentations of DVT as such, in which the most sensitive one is swelling. Okay. So this patient presented with this, your past history, when you say this case, it's a young female, right? What is one of the most important past histories you need to mention, negative past history?
Previous history of
DVT. Yes, and
cancer.
What others? What other things?
Any hormone therapy she is taking.
So what are the risk factors for deep vein thrombosis?
So deep vein thrombosis, risk factors can be divided into 3 types. They can be due to either stasis, due to endothelial injury, or it could be due to hypercoagulation states.
Okay.
Under hypercoagulation, it can be pregnancy, postpartum, malignancy. It can be due to infection or sepsis, estrogen treatment if anybody is taking, inflammation, dehydration. Then vascular damage could be due to thrombophlebitis, cellulitis, atherosclerosis, any physical trauma to the physical trauma, or then strain or injury. And stasis due to prolonged immobility, long hours of travel, then varicose veins, previous history of varicose veins, or any congenital abnormalities if present.
Yeah, so these are the risk factors for DVT, right? But when we talk with the patients, when you take history, what are the important negative histories you need to ask?
Negative history.
Here you told she is pregnant, so
Yes.
that is one of the positive histories for DVT.
Yes.
What others? She is a young female. Autoimmune conditions need to be asked, right?
Yes.
You told the vascular
Abortions,
injury. So vascular injury means vasculitis is a form of vascular injury. So previous history of DVT, not only previous history of DVT, previous features of autoimmune diseases need to be asked for this female. It's a 20-something plus female, so previous pregnancy history, multiple abortion histories need to be asked. Whether rashes or exposure to sunlight need to be asked. Any previous thrombophlebitis in anywhere in the body, that is previous CVA, upper limb thrombophlebitis or thrombus formations need to be asked for this patient. This native history is important in that part, autoimmune condition. What else? Whether she is on OCTs, anyhow, right now she is pregnant, that history is not indicated as such. Other thing, what you told is dehydration. So if a young female is, not young female, any young patient is coming directly with any acute thromboembolism. severe dehydration should be suspected for them. So history of heavy alcohol intake, heavy exercises need to be asked for this kind of patients. What else? No?
Drug history.
Yes, drug history.
Operations.
So what are the drugs that can cause DVT? OCPs. What else?
Hormone therapy, estrogen.
You are thinking about drugs that can cause DVT. What else can indirectly cause DVT?
If a patient is on like any
Anticoagulant.
anticoagulant,
Correct.
stop
Already
It's
on
not only drugs
anticoagulants.
that can cause DVT, withdrawal of drugs. Patient was on warfarin, patient was on acetrom, patient was on dabigatran. The patient stopped it. Patient can develop systemic thrombosis. And one more history, important history is previous arterial vascular thrombus should also be asked. There are conditions causing venous spontaneous venous thrombosis. This is a spontaneous venous thrombosis. No, patient doesn't have any classical features of involvement, vascular injury as such. Only condition is pregnancy. Other than that, she is a mobile patient, young patient, not a bedridden patient. Other comorbidities are not there. Obesity is not there. So this is spontaneous venous thromboembolism. So when there is spontaneous conditions that cause spontaneous venous thromboembolism, there are conditions that can cause spontaneous arterial and venous thromboembolism. It's a autoimmune conditions, deficiencies, complement pathway deficiencies and all. So that history as such, complement pathway and all, patient may not be able to tell you, but you need to ask history about general autoimmune disease conditions. That you can ask. Okay, CVA histories. Okay, so those native histories you need to ask, because when you say what are the risk factors of DVT, those risk factors we have to ask in history to rule them out, right? Okay, what else?
In all patients for any malignancy.
Any malignancy as such. So,
Smoking.
if this patient is a pregnant lady, so she came, you ask the native histories, and on examination, what are the signs and symptoms you get on examination?
So, swelling that would be around 3 centimeters more than the other limb.
Okay. So calf measurement should be more than 3 centimeters in comparison to the opposite limb. What else?
Then temperature.
What is the classical presentation of a DVT?
Cramping pain.
No, unilateral.
Unilateral swelling.
Limb edema.
Limb edema.
Unilateral pitting limb edema is what we are looking for. Does that mean bilateral pitting edema is not DVT? What is a condition in which you can get bilateral pitting limb edema and DVT due to DVT?
Iliac pain.
How many iliac veins do you have?
IVC thrombosis.
IVC thrombosis. So, unilateral limb edema is very common for DVT. We will all think of DVT. Bilateral limb edema should also, a DVT history we should think, especially patients with the malignancies. What type of malignancy patients are prone for IVC thrombus? All malignancies are prone for IVC thrombus, but also abdominal cancers. So, uterine carcinomas, ovarian carcinomas, those, the mass itself can impede venous circulation, IVC constriction or IVC obstruction causing venous stasis, causing DVT. So, if a thrombus is in IVC, you can have bilateral pedal edema. So, then these high risk factors are very important. Presence of malignancy, presence of bedridden. In that conditions, you have to look for where is the edema. So, usually you get calf edema, right? Calf and ankle area is where the maximum edema occurs. But proximal, the DVT is, the edema will move proximally. So, patient's thigh can be significantly edematous. So, above knee edema should be significantly thought about proximal thrombosis. That means not only the femoral vein, we can think about external iliac, common iliac involvement also. So, proximal, how much ever proximal the edema is, that much proximal thrombus we should suspect. Okay, so position of thrombus, presentation, then Hoffman sign, right? What is Hoffman sign?
On passive dorsiflexion, there will be severe pain on the calf.
Okay, so that can be checked into, but Ideally, if you have high risk of DVT suspicion is there, it's better to go for diagnostic test in the current scenario, because even if you do the clinical examinations of pentastandard, the specificity is pretty low. So it's better to go for a definitive diagnostic test, that is Doppler of affected lower limb or bilateral lower limb. Venous Doppler study is better rather than going for Hoffman study because of much more higher specific value, especially in emergency department. When you are looking for venous Doppler, if you suspect any abdominal mass lesions or malignancy, just ask the radiology to screen the IVC also, just to make sure the thrombus is not extending. Now, not only that, IVC thrombus, we want to classify it as DVT. Proximal, the thrombus, high risk for the thrombus to move upwards, causing cardiac involvement with the pulmonary embolism. So, we want to know what is the level of thrombus to stratify whether it's a high risk thrombus or not. Okay. So, presentations, right? Okay. Now, what are the investigations of choice? As we told, venous Doppler. So, what do you look for in venous Doppler?
The flow, like the
valves. Or, of course, radiology will look for thrombus inside the vein. Radiology's idea of DVT, diagnosis of DVT is identification of thrombus inside the vein. You can see a vessel which is blocked off with some luminal matter inside. So you can understand, oh, this is DVT. And a good radiologist may tell you about the chronicity of DVT also. In emergency, as an emergency physician, how can you use ultrasound to identify or look for the patient with the risk factors for DVT? You want to rule out DVT, how can you do that?
Flow, duplex scan we can do.
Doppler scan is there, but then you need to assess the flow. What is compressibility is the most easiest way an emergency physician can assess whether there is DVT or not. What is compressibility? The distal part of the affected vein usually will not be compressible on probe pressure. So you need to understand that only the distal part of the vein is non-compressible. So you put pressure on superficial femoral vein opening, and if vein is compressible, doesn't mean patient doesn't have DVT. It's just that it may be lowered down. So there are three areas you check. That is your femoral vein, your popliteal, and your tibial below. So these are the three areas you can broadly check whether compressibility is absent. If absent, your suspicion of DVT can be quite high. Okay, fine. So ultrasound. What are the blood investigations that you will do to confirm DVT?
So to confirm, so we can look for polycythemia in CBC if is there.
But the question was what to confirm.
D-dimer, but it is does not.
Will you do D-dimer to confirm DVT?
Not to confirm.
You should not do D-dimer to confirm.
That is negative predictive value only.
Yes.
To rule out DVT, we can.
Yeah. So if you have unilateral limb edema, and the patient doesn't have malignancy and you want to make sure it is not DVT, you can set a D-dimer value. D-dimer value comes back as normal. You can say this patient is not having any thrombus, active thrombotic events in the body. Basically, you are telling there is no active thrombotic event, be it DVT, be it venous thrombus or arterial thrombus in anywhere else in the body. So, negative predictive value. But there is no blood investigations you need to do to diagnose. Diagnosis is purely either clinical or with radiological. So, easiest one, as we told, is Doppler, venous Doppler, right? What is the definitive test? Gold standard. CT, distal venogram or proximal venogram, whichever is affected. CT is the gold standard. It will tell you the size of the thrombus, extent of thrombus, and age of the thrombus. It can be acute venous thromboembolism, subacute venous thromboembolism, or chronic. So, age of the thrombus you can identify with CT. But CT absolutely is not necessary for acute thromboembolisms, especially if it is a distal thromboembolism. You really don't have to do a CT to diagnose it. Doppler is good enough. Okay. What other ancillary tests will you do? You told CBC because polycythemia you want to see. So increased viscosity conditions, right? Polycythemia, then thrombocytosis. Okay, then coagulation profile. What is coagulation? PTNR, APTT, and PTNR, APTT. Okay.
Protein C, protein S deficiency.
Will you do protein C, protein S in acute thrombotic event? Protein C and protein S will be used to form the thrombus as such. So, in acute events, you don't have to send. And in emergency department, protein C, protein S is not an emergency department investigation. But even if you do, it should not be done at the time of thrombotic event. Okay. What else? What are the other ancillary tests?
Chest X-ray, ultrasound.
Yes, you can send for autoimmune condition screening. So, anti-DS DNA, ANA profile that you can send. Especially that is important for spontaneous venous thromboembolisms. No identifiable risk factors are there. You need to send for autoimmune workup. Okay, what else? What other ancillary tests?
X-ray, ultrasound, like to rule out any
Why you want to do X-ray?
Malignancy. If only we are suspecting any malignancy.
Okay, what else? What are the abnormalities in vitals for a DVT patient?
Saturation of less than 94%.
So you can have tachypnea, desaturation and tachycardia. So if a DVT patient is having tachypnea, desaturation and tachycardia, what will you suspect?
Pulmonary embolism.
Pulmonary embolism. So what is the ancillary test you will do to rule out pulmonary embolism?
Confirmatory CT pulmonary angiogram.
That is true. What are the ancillary tests?
Chest X-ray we can do.
Chest X-ray. What else?
Ultrasound.
Echo and ECG. What are the ECG findings of pulmonary embolism?
Sinus tachycardia.
Most commonest one, most sensitive one is sinus tachycardia. Then followed by
Right bundle branch block.
complete or incomplete right bundle branch block. Then
And specific is S1Q3T3 pattern in ECG.
yes, most specific is S1Q3T3, but it's quite unusual to get such a presentation. But ECG is required for all DVT patients if they are having tachycardia or if they are having desaturation, because pulmonary embolism is an eventuality for a DVT patient. So that should be ruled out. Okay, and if you have desaturation and ECG change like tachycardia is there, you should actively suspect pulmonary embolism. So you told echo, right? What in echo are you looking for in pulmonary embolism?
RA-RV dilatation.
Okay.
Then septal movement to the left side.
Okay.
And
Acute TR.
acute TR.
Basically, there is a thrombus in pulmonary artery which is increasing pulmonary artery pressure. One of the first things that will cause is acute TR. Acute TR jet is one of the most specific findings of pulmonary embolism, followed by RA-RV dilation and septal movement towards left. Now, in all cases of pulmonary embolism, will you get RA-RV dilation and septal movement disruption?
So only large thrombosis.
Yes. So when you have moderate to severe pulmonary embolism, only you will get all this. Basically, the thrombus has to be either in the main pulmonary artery or at least in the right or left pulmonary artery branch. It should be obstructing a huge amount of blood flow. Then only cardiac stress levels will come up. So ECG is one ancillary test you will do. Then you have to, as you told, coagulation pattern, blood test, other organ diseases. Any reason to do RFT?
CT pulmonary angiogram, creat should be checked.
Yeah, CT pulmonary angiogram, but more than that, treatment part. You need to start on treatment. You need to know whether patient's kidney is functioning properly or not. No? So baseline creatinine is very important before choosing the agent for treatment, anticoagulation. Now, Coming with our diagnosis, our ancillary test, you form the diagnosis of isolated venous thromboembolism. What is the diagnosis? What is the treatment for that?
So anticoagulation.
How do you anticoagulate a patient?
So we have different agents. We have unfractionated heparin, we have low molecular heparin, and we have the novel anticoagulants, so the newer ones.
What are the newer ones?
There can be some direct thrombin inhibitor.
Like?
Direct thrombin inhibitor is dabigatran.
Okay.
Then so we have factor 10A inhibitors, which are apixaban, rivaroxaban.
Okay.
Those.
So what is the most commonest? Readily available?
Unfractionated heparin.
Unfractionated. What is the drug of choice for this female?
Low molecular weight heparin.
Low molecular weight heparin. Much more easier, much more safer to control, right? So ideally, if any patient comes with a DVT, how do you start anticoagulation?
So we start with injection heparin.
Okay.
Like we
What
give
is the
stat
dosage?
dose, 80 milligram per kg body weight stat we give, and then we can also give infusion at the rate of 18 units
What
per
is the
kg body
indications for infusion?
infusion.
All DVT patients will you give infusion? No. So what is the criteria to give infusion in a DVT patient?
Usually in the proximal DVTs we
Yes,
give.
proximal the DVT, more in major vessels, that is common iliac and higher, we give
Infusion.
heparin infusion. Otherwise, start bolus doses are more than enough. Okay, so 80 international units per kg bolus dose will you give, and
Along with that, sir, we can also start on warfarin simultaneously.
So why do you start warfarin along with heparin?
Because warfarin's onset of action will take place only after around 5 days.
Okay.
So till then, we
You are
start
bridging with
the
heparin
gap
till the
between-
warfarin's effect starts, right? Okay, then you stop heparin by the 5th to 6th day, and you adjust the warfarin's dose as per patient's INR
value.
and plan discharge. Okay, so why you didn't start warfarin in this patient?
So because she's a pregnant lady, it will cause fetal warfarin syndrome.
Yes, so in pregnancy, warfarin should not be given as such patient. If a patient already is on warfarin, during pregnancy, it should be converted to heparin, especially during
First trimester.
first trimester. Okay. So since she is in 8 weeks, we started on NOH heparin. Okay. What is the advantage of NOH heparin in comparison to heparin, unfractionated heparin?
Doesn't need monitoring of the PTA. Doesn't need monitoring of APTT.
The
PTA.
action, anticoagulative action is not dependent on APTT levels as such. You can give fixed doses and patient will get anticoagulated. Low risk for spontaneous hemorrhages in comparison to unfractionated. Okay, so you started on NOH heparin. Any other drugs, if it was not a pregnant lady, it is not a pregnant lady, it's a maybe like a 60-year-old female or a male post hip replacement. So they develop DVT mainly because of bedridden condition, right? What are the drugs you would prefer to start for these patients, these kind of patients? Got the question, right? It's a middle-aged patient without much comorbidities, very stable, developed DVT, not due to spontaneous, not due to any other causes, but due to bedridden state, that is stasis of the blood. Do you really want to admit such cases? In our institutions and most of the institutions, acute DVT will be admitted. But ideally, distal DVTs with the bedridden status patients, you don't have to admit. You can discharge the patient on oral anticoagulants. What are the drugs?
The newer drugs.
Yes. Rivaroxaban or dabigatran, you can start and discharge the patient. Only thing is, you need to ask the patient to come every 48 hours to recheck whether the patient is developing any features of infection in the thrombus or whether there is any worsening of the thrombus, that is proximal extension is there or not, for a repeat scan or clinical examination. Okay, so if you are starting the patient on dabigatran, what is the dosage?
So dabigatran dosage is 150 milligram BD.
Okay.
It has to be after 5 to 10. It can be started only after parenteral anticoagulation. Initial parenteral anticoagulation for 5 to 10 days. After that, we can convert to 150 milligram BD.
And rivaroxaban?
Rivaroxaban, sir, we start 15 milligram BD with food for 21 days, and after that we convert it to 20 milligram BD with food. It has to be.
Rivaroxaban needs parenteral anticoagulation?
No.
So rivaroxaban is a drug you can give the patient and discharge if it is a simple DVT outside, means distal DVT as such. Now, anticoagulation we are told. If a patient presents to ER with unilateral lymphedema, what are the risk factors? Not the risk factors you have put up. There is something known as, before doing all these Doppler studies and all these things, there is something known as pre-test probability. Yeah, what are the things? What are the things that will help you to assess?
Pre-test probability. So we can use the modified Wells score for that.
Okay, what is modified Wells score?
So it contains, we give up 1 point each for all the criteria.
Yes.
So it includes if the patient is having any active cancer, treatment ongoing or within the previous 6 months, we give 1 point for that. Next, paralysis, paresis or recent plaster immobilization of the lower extremities, recently bedridden for more than 3 days or any major surgery within the last 4 weeks. Then localized tenderness along the deep venous system, entire leg is swollen, then calf swelling by more than 3 centimeter when compared to the asymptomatic leg, pitting edema greater in the symptomatic leg, then previous documented DVT and any alternative diagnosis is more likely than that of DVT, that we would give 2 points. Other all will contain 1 point, and
alternative diagnosis?
Any alternative diagnosis is more likely. Alternative
likely.
Diagnosis as likely or more likely that of DVT. That is minus 2 points. Sorry, that is minus 2 points. That is minus 2 points.
Actual Wells criteria, one of the first point is alternative diagnosis is unlikely. Unlikely. So that is minus 2 points. Okay. So how do you classify?
So if DVT, if the point is more than 1, then if it's more than 2, then it is DVT likely, and if it is less than 1 or 1, it is unlikely.
Unlikely. Okay. So this is a pre-test probability in which you can assess the patient to see how risk stratified the patient is for developing a DVT as such before going for Doppler studies for everyone. No. What else in DVT will you do? When will you ask the patient to come back to do a repeat venous Doppler scan?
So first, after 7 days, we check if there is any extension before discharging. If any extension of the thrombus is there, if there is not any extension, then patient can go home and continue on that medication for 3 months. After 3 months, patient has to come back and
so frequent revascularization scans are not required. The first only scan that is required post diagnosis is at the end of whenever you are discharging the patient to assess whether there is any growth of extension of thrombus. If there is no extension of thrombus, then only after 3 months you need to check for revascularization, and that is only in spontaneous thrombosis. In non-spontaneous thrombosis, that is previous DVT histories, autoimmune conditions, revascularization is checked at 6 months of duration. Okay. What else? Anything else?
For how long the anticoagulation should be taken?
How long the anticoagulation should be given?
For isolated DVT to the upper limb or calf that has been triggered by surgery or trauma, for 3 months we can give. If it's the first episode of venous thromboembolism with reversible risk factors like travel, OCP, hormonal therapy or minor trauma, or if it's a proximal DVT, we give it for 6 to 12 months. And venous thromboembolism with malignancy or inherited hypercoagulative risk factors for lifelong or long term.
Anything else? No. Fine.